corn. All right. So remember, no matter what medication we're going to administer the patient, no matter what route we're going to give the medication, it is very important that we follow the following guidelines. We reviewed this when we were in lit. So first and foremost, you have to understand why the medication has been ordered. So you want to do your 3 checks. What are your 3 checks? When you are reaching for the medication,
Compared to
when
the
you're comparing it to the EMR, right? And then the final is at the bedside. Very good. Okay, very good. All right. You have to also make sure that if there are any specific guidelines or parameters for the medication. For example, what if you are giving digoxin? Chances are you're gonna have to do what?
I have to check their pulse if it's more than 6 beats. I have to give that medication.
Right. So you're gonna do at least the apical radius. If you're giving a certain antihypertensive drug, what might the provider want you to do?
Check blood pressure.
Check the blood pressure. Very good. Okay. If I am giving, let's see, ointments for the eye, how do I do that?
You have to
At
drop
the
a little
bottom
bit.
leg.
Head and neck, and you bottom of the eye.
But even before I do
You
that,
squeeze some out.
remember
If
you
it's
discard the
antibiotic.
first feed.
Yes.
okay? So review how we give an eye drop, or I'm sorry, an eye ointment. You discard the first feed, right? Tilt the head back, of course you always wash your hands, gloves, tissue, all of that. You explain to the patient what you're doing, you're gonna pull down the lower lid, and you're going to put it right in that lower lid, right? You'll ask the patient to close the eye, right? And the warmth of them closing the eye kind of disperses the medication. Obviously, you're not going to put eye ointments in both eyes and then have the patient do an activity because their eyes is gonna be blurred because it's an ointment. What about for an eye drop? What's the process for an eye drop? You do your hand hygiene, all of that, tissue, blah, blah, blah. And how do you do the eye drop?
You drop it in the lower eyelid, inside the
Pull the lower
eyelid.
eyelid down and you're gonna drop it right in that lower eyelid. You're not gonna drop it on the eye itself. You're gonna drop it in the eyelid. And then you have your tissue, so because as soon as you drop something in the eye, you have that instant reflex, they're gonna blink, you wanna be able to put the tissue in the corner of the eye. And that, if you put the tissue in the corner of the eye with just a little bit of pressure, it helps to keep the medicine in the eye, so it doesn't run down the face, okay? And what side am I, if the patient can't tilt their head back, and I have to put them on the side for an eye drop, I'm doing it in the right eye. Do I turn the right side? No, put them on the affected side.
Oh.
Because it's gonna close it.
Because if you put them on the unaffected side, the drop could roll and go in the eye.
Right.
So put them on the affected side. Okay. Only if they can't tilt their head back, okay? That's just a little trick that you guys can be aware of. Okay. And remember, you give medicine as per your agency policy. So if your once a day is at 10 o'clock, okay, you try giving it at 10. If it's at 9, you give it at 9, however they dictate to you. Okay. And then if you are giving something that you need to evaluate afterwards, such as a pain medication, an opioid, Percocet, Percodan, giving it orally, when would I evaluate that?
So let's say, for example, the medication is supposed to, work after 30 minutes, I'll
Yeah.
come back when.
Yeah, so you give about 20-30 minutes for a peel, right? Because it's gotta digest a little bit. Now, what if my patient was to be medicated for pain, and I went in and I assessed the patient, and maybe, I don't know, maybe their blood pressure was a little bit low, maybe their respirations were a little bit low. Would I give that opioid?
No.
Why not?
Because it's gonna even lower the.
Okay, remember if you were making your cards, any narcotic is gonna depress the respiratory system, right? So you just wanna be mindful of that. So even if the provider doesn't write a parameter for something, you should know as a nurse, that's part of your assessment, right? You would always assess your patient. What if you were giving, a hypertension medication and you checked the patient's blood pressure and it was much, much lower than it normally would be, so say it was like 80/70.
Did you say hypo? Say hypo?
Hypo, it was 80/70, 90/70, whatever. Would you give that antihypertensive? No, you would call the provider first, right? Because it's gonna drop it even further, okay? And remember, even if somebody is hypertensive, they could change, you know, maybe they're sick, you know, maybe something else is going on with them, and their blood pressure can fluctuate, right? Remember, we're not the same number all the time, which is why you need a good nurse, right? To evaluate us all the time and assess us. Okay. MDI, we're gonna do this as part, I believe, of the medications, but what does MDI stand for? I did it yesterday. Meter dose inhaler, otherwise known as a HFA, high flow aerosol, right?
Like the Ventolin. I don't remember the name.
Okay, give me an example of a medication that we would use as an inhaler.
Ventolin.
Albuterol, a rescue for asthma. Yes? Some of you are looking at me like you never heard me say this before. How do you do it? How do you teach a patient how to use a meter dose inhaler?
Shake it.
Shake a canister, that's good. Then what do you do?
Close to the mouth. I think we're supposed to spray one to the air to make sure.
That's if you wanna test it, yeah,
Right.
you could do that.
And then put it in the mouth with the lips around, close the lips, and then, spray first, excuse me.
She's getting very excited.
Excuse me. Hello. Are you gonna teach her excited? She's like, I'm
Cause you're gonna have a lot of patients that get medication through an inhaled route, right? So you gotta, you're good, you understand.
Electronics.
One,
You continue.
No, finish.
wonderful,
Excuse me.
wonderful. Okay. All right, let's talk about cardiac meds, okay? Cardiac meds, you have your ACE inhibitors, your PRILs, for example, captopril or captopril. What do these drugs do? They decrease blood pressure by decreasing cardiac output or the peripheral vascular resistance, okay? That's how they act. So remember I said sometimes you will see drugs with a certain either suffix, prefix, or suffix. This one, pril, okay, those are the ACE inhibitors. They'll always have pril at the end, okay? The LOLs, okay, these are the beta blockers, okay, such as metoprolol, which the other name for that is Lopressor. Then you have your calcium channel blockers, for example, diltiazem or cardizem.
It's not the same thing? The
Yeah.
metoprolol is not the calcium blocker?
What's that?
The metoprolol.
The other name is Lopressor.
Right, it is the calcium blocker. Oh.
It's a beta blocker.
It's a beta
It's a
blocker,
beta
not a
blocker.
calcium blocker.
Calcium channel blockers, for example,
Oh,
that
I'm
would be
looking for
diltiazem or partizan and lidocaine or Norvasc. And DIG or Lanoxin is the cardiac glycoside. So those are the classifications of different medications. Captopril or Capitan is a good first-line drug for those patients who have hypertension and diabetes.
Which one?
It's good for that. Okay,
Okay.
it slows
First one.
the progression of renal disease, and your diabetic patients eventually will wind up with some type of renal impairment. So if you made a card with any of the captoprils, pills, the ACE inhibitors, what are some side effects? Does anybody know? Coughing, right? A persistent cough. That is a very common side effect.
Why does it cause cough?
It stimulates, the medication stimulates the phrenic nerve, and the patient coughs a lot. So if it becomes a quality of life issue, they may want to try and change it, but just know that it's a side effect, okay?
Do they stop this medication if the patient is coughing?
Maybe it depends. If it really bothers them, it's a quality of life issue. Yeah, they might do that. Depends, they have to see how the patient does. Sometimes the patient can be sensitive to the medication. And that's why we always start folks on a low dose, okay? Sometimes if you're not used to taking something, and even if you give a little bit of a low dose, they can become hypotensive. So they're always monitored when they are started on any new medication. And you remember, you start low and you titrate up. That's with all medications. Sometimes they can get dizzy. If they get hypotensive, they can get dizzy. And with the prils, the ACE inhibitors, the patient can also develop a hyperkalemia. Hyperkalemia, so that's a high potassium. What's the norm for potassium?
3.5 to 5.
3.5 to 5, so it would be over 5. Okay, potassium is a very finicky electrolyte, because if it's too high or too low, it has a direct impact on the electrical conduction at the heart. That's why we pay such a close attention to it.
Does it affect the kidney? It's gonna slow down.
It could, yeah, it could, it could, it's definitely the heart. Okay, the beta adrenergic blockers, the beta blockers, the LOLs, how do they help the heart? They decrease the cardiac workload of the heart by slowing the rate. Okay, so someone who is on a beta blocker would normally have a lower heart rate than if they were not on a beta blocker. So when you slow the heart rate, you decrease the workload of the heart. The heart doesn't have to work as hard. And a good byproduct of that is that the blood pressure is decreased. Okay, so it has an additive effect. Very good. What else can I tell you? Okay, so if, by the same reason, if you're giving somebody a beta blocker, LOL, like metoprolol, what would you watch out for before you give it?
Blood sugar.
Oh.
You would watch for a lower heart rate, right? So maybe my patient is more sensitive to it. Maybe we're giving 50 milligrams of metoprolol, and it makes my patient's heart rate 40 beats a minute. That means what?
You have to stop it. It's
It's
making bradycardia.
bradycardia. It means I don't know if I would stop it, but I would definitely call the provider, and they may change the dose. They're gonna decrease the dose, okay?
Would they normally have a normal low heart rate?
being that they're steadily on this medication?
Usually, yes. If they're steadily on it, their heart rate should be lower.
But then when you give it, it goes lower.
Correct.
So then you watch it to see if it's gonna go lower.
So
like
you're
to
the
its lowest
nurse,
point.
you're giving the low pressor today,
Mhm.
and usually it kept your patient's heart rate around 60, 62, whatever. And now today it's 40. Oh, I'm not gonna give that low pressor.
Hmm.
And I'm gonna call the provider. Maybe the provider may say, hold that dose. Maybe we'll decrease the dosage. Okay, that's up to them. I'm just trying to make you aware with any medication, you still have to kind of assess your patient.
Right.
Yeah.
Thank you.
You would also assess glucose levels, right? Because it could mask the symptoms of low blood sugars.
Yes, and I saw that.
Depends on the,
So not always.
not always.
Okay.
Not always, yeah, not always. Okay. Digoxin. You must have made a med card about digoxin. Tell me about digoxin.
No.
It's a heart medication.
It's a heart medication. What are you looking for it? What are you looking for with digoxin?
You told us yesterday to, we have to take the pulse, the apical pulse before giving
Apical
it.
radial pulse, very good. What's a side effect?
Halos.
What's a halo?
It's like a ring around the person's,
It starts to see, like
like rings.
green, yellow color.
They have it or they see it?
No, it's a side effect.
They see it.
Yeah.
Around light.
Yeah, around lights, okay, so that's a very common symptom. And remember, we also monitor digoxin levels periodically, because why?
Because it can become.
Ditch toxicity, right? And that means what? There's too much digoxin in the bloodstream, and what does that mean? Yep, and that could be very toxic, so you wanna be very careful about that. Okay. Your statins. Okay, what is a statin? It's a cholesterol medication, so it's an anti-cholesterol medication, hyperlipidemic. Why are these meds important? We just gave there's just two examples up here, atorvastatin, Lipitor, and fluvastatin, Crestor.
Parents coronary artery diseases.
Very good. When would we give this to a patient?
High,
When they have high cholesterol,
Yes, and how do we know that they have high LDL?
the blood test.
Blood test, okay. So if you have high cholesterol, plenty of people walk around with it and they don't even know it, okay? It can clog your arteries, it can clog your cardiac arteries, it can clog your carotid arteries, anywhere in the body, artery, it can clog. And what happens is, it's like a pipe that gets narrower and narrower, and the blood has difficulty moving. So the heart is working harder to push that blood through arteries that are very narrow. And then what can happen, a piece can break off, it can go travel somewhere and get stuck. And then what happens? Now there's no circulation, the patient can have a heart attack, right? They could have a stroke, so the consequences are pretty severe. So as nurses, yes, if the provider orders a medication such as this, we're gonna give it, okay? We're gonna monitor the patient. We're going to teach the patient about the medication. But it's not always about the medication, okay? There's a lot more than just the pharmacological viewpoint. What else are you going to be talking to your patient about?
The diet.
The diet. Remember, cholesterol builds over time. It takes a long time to get those arteries clogged. So you gotta figure it's probably, 20, 30, 40 years of eating certain kinds of foods that, and then plus it's your genes. Don't forget about your genes. Some of us are just more prone to having high cholesterol than others. So it's always good to make sure you take a sample of somebody's diet, ask them to keep a diary for 2 weeks, write down everything you eat. Well, first we gotta do the diet, right? We gotta see what they're actually eating. And we gotta teach them, what's low cholesterol and what they should avoid. And then we can incorporate exercise, definitely we can incorporate exercise. Okay, so the goal of giving any type of statin or cholesterol drug obviously is to decrease the production of that cholesterol in the body, thereby lowering the levels. So periodically, you would go to your physician, your provider, they will do blood work, right, to check the levels of the cholesterol. So they'll check the total serum, the LDLs, the HDLs. And also, if the patient takes this medication in conjunction with a healthy diet and exercise, it should drop the levels. Okay? So that's the goal. Remember, that's always the goal. We don't just give them a medication. We want to change lifestyle behaviors, and those are the ones that are difficult to change. Usually, we give these meds once a day. You're supposed to give them at what time? At bedtime. Why?
That's when the liver produces.
Very good. That's when the liver produces all the cholesterol. Very good, very good. Okay, so a normal cholesterol, a normal total cholesterol, we like it to be under 200. And which is the good cholesterol, the HDL or the LDL?
HDL.
The HDL is the good cholesterol, right? So if we add some dietary changes and some exercise, the HDL should go up, but of course it takes time, all right? It takes about 3 months before you see any effect. And what is the HDL? Should be? It should be greater than 40. Greater than 40, yeah, the higher the better, the greater than 40. And the LDL, which is the bad cholesterol, should be less than 100. And not too many people have that, if you think about it. Do you all know your cholesterol?
No.
You should always know your baselines. So some common side effects of the statins are what? Muscle cramps, okay, especially in the calf. So what happens if your patient complains of muscle cramps? Not necessarily hold it. You might want to decrease the dosage.
But does that just go?
No, you wouldn't do it, the provider would do it, right, but you would call the provider. You don't wanna just, have the provider say, stop something. Okay, usually providers will start patients on a dosage of statin depending on their initial levels, okay? But again, everybody's physiology is different, so it's always better to start low and titrate up. Okay, so I think doses start at 5 milligrams. Sometimes if the dose is too high, they get the leg cramps. They can also suffer from nausea. If the dose is not agreeing with them, they can have constipation or diarrhea. It can affect them either way, GI. It can also give them a headache. Well, you're not supposed to smoke. If somebody is smoking, you gotta get them on a smoking cessation program, right? Okay, so the next one is your diuretics, okay, your water pills, okay? When do we give these medications?
In the morning.
We're supposed to give them in the early morning, okay? It's not good to give a diuretic at nighttime because what is the therapeutic effect of a diuretic?
The urinary is more.
Increased urinary output. So if I give this to my patient patient at 9, 10 o'clock at night before they go to bed, are they gonna have a restful night's sleep?
No.
No, they're gonna be up and they're gonna be urinating all night long. And if it's an elderly patient, it increases my falls risk dramatically. So, no on both counts, right? So we give it early in the morning. Okay. When we are giving a diuretic, whether it's a thiazide or a loop, you want to see an increased urinary output, correct?
Yeah.
All right. You also want to make sure that your patient, especially when they're home, if you are giving this diuretic, maybe they have congestion in their lungs, they have congestive heart failure, that they also weigh themselves every day, okay? Do you know that?
Yes.
Okay, so tell me why.
Because the water is gone.
Because if they're urinating, they should be losing that water weight, right? Okay, so if my patient runs out of a diuretic and they eat some salty food, yeah, what's gonna happen? They're gonna swell, so how will they know that they're retaining
Water.
right,
weight.
the everyday weight? So you would instruct your patient to weigh themselves on the same scale every day, at the same time, approximately, with the same clothes. Okay, so that this way they understand that if they're putting on weight, it's because there's something else going on. And we usually tell the patient that if they gain more than 2 pounds in a day, to call the provider, because that means they're holding on to water. We don't want them to wait until they can't breathe, and the ambulance is bringing them into the hospital because they're short of breath. Good. All right. So now we understand what we need to teach the patient. Now, when you are assessing the patient, what part of the body are you going to do a focused assessment on?
Blood pressure.
Definitely blood pressure. Lungs. Lungs. Are we not listening to the lungs?
Yeah, to
Because
see if there is
remember,
any
if your
water.
patient is gonna fill with fluids, they're gonna become short of breath. Why are they short of breath?
Because they have
Because
fluid
their
buildup.
lungs have what? What in them? They
Water.
have water, so what would you hear?
Crackles.
You would hear crackles, very good, okay, excellent, alright. And you can also check their pedal pulses, their ankles, their lower limbs for edema. Okay, what's edema? Swelling, how do I know it's edema and it's not something else?
If they have,
Press the finger.
You press it, right? You press it gently and you see how deep of an indent you make into their extremity and then how long it takes for that extremity to, the indent to go in. And that's how you know that they have edema. Okay, so your thiazide diuretics, your hydrochlorothiazide or hydrodiuretic, what do they do?
Lowers the blood
Well,
pressure.
it acts a little different, right? So the thiazides decrease the reabsorption of sodium, water, and chloride. And what do the loop diuretics do?
Inhibit sodium and chloride reabsorption.
Very good, very good. So, let's go back to the thiazides, that classification. Okay, hydrochlorothiazide is one of them. What are some common side effects? Hypokalemia, hypochloremia, hyperglycemia, hypotension, right? Weakness, dizziness,
erectile dysfunction for men.
Mhm. Also, they can suffer from decreased magnesium levels.
Hypoglycemia or hypo?
Professor, why cause hypoglycemia?
Hypokalemia,
Hyperglycemia.
hyperglycemia.
Why called hyperglycemia?
Because of the way it functions, it can have a rebound effect on the glucose. So if your patient is diabetic, you would assess it. That's they would do it. Your loops, again, this is the drug of choice if you want what your colleague says is a fast acting diuretic. So for example, if your patient comes in with heart failure and they're short of breath and their O2 sat is low and they have rails halfway up their lungs, you're going to give a loop, okay? You're gonna give furosemide or Lasix, and that's gonna promote rapid, okay, it should promote rapid release of urinary output. Now, in that particular patient, do you think you might put Foley in them?
Yes.
Maybe we don't like to do invasive, but if we're doing strict intake and output, we might. And your patients that you would take care of that have a history of COPD, that you would be giving them diuretics, would you weigh them every day?
Yes.
Yes, you would, you absolutely would, okay, because you're looking for the same thing that you teach them to look for at home, which would be an increase in water retention. And would you also weigh them the same time, the same scale, the same?
Mhm.
Yes, you would, absolutely, okay. So one thing with the loop diuretics, you have to make sure that your patient is not allergic to any sulfur or sulfonamides. Okay, because that is an interaction. So if they're allergic to sulfur, then they can't have a loop diuretic. And it's always better to give this particular medication with food, okay? Especially because food acts as a buffer to minimize GI upset in patients with sensitivity. And all of our elderly patients have some type of GI sensitivity, correct?
So, we are waiting for both the thiazide and
You're
the.
weighing for both, yes.
Okay.
Any diuretic, you're gonna weigh them, for
Okay.
sure, for sure. And some common side effects of furosemide or Lasix, hyponatremia, hypokalemia. Think of fluid volume deficit because you're pulling off fluid quickly. They can become hypotensive if you just swing them the other way. And if you give too much Lasix, it can be ototoxic. Okay, so it can affect their hearing. So if they're on heavy doses of this, you're gonna do blood work, right? And you're gonna look at all of your electrolytes to make sure that there are no abnormalities, and you're going to address it accordingly. Hypokalemia or low potassium is very common with a loop diuretic. It pulls a lot of potassium out of the body, so if your patient is a bad heart failure patient, they may be getting a loop diuretic, and they also might be getting a potassium supplement to adjust for that. Yeah, definitely. Okay. Your anticoagulants, okay, there are several different drugs that are on the market for the anticoagulants, okay? And they are enoxaparin or Lovenox. There's also heparin, or warfarin or Coumadin. Warfarin Coumadin is like the oldest one of all. It's been around for 1,000 years. tried and true, some of them are newer. Heparin is, a little bit, obviously an anticoagulant, and that's the class, but it's cheaper to give a patient than enoxaparin or Lovenox. You saw what the, Lovenox, syringe looked like, it's pre-packaged from the company. So it's a low molecular weight heparin, it just costs a little bit more. They both have the same effect, but you will see some places will use heparin, some places will use enoxaparin. But again, the effect is the same. So when is the most common that you would give these injections? What's wrong with the patient?
Blood high.
DVT, good,
Yeah.
or risk for DVT
After
because
surgery?
they are on
After
bed
Laying
rest.
down.
Bed rest.
Yeah.
Yes, so if your patient is on bed rest because they're very, very ill, I mean, well, now we're gonna get a couple of doses of an anticoagulant. I've actually seen facilities that routinely give an anticoagulant. I know, that's what I said. I was like, whoa. You know, it's just like a risk mitigation thing. I mean, you know, if somebody is up and ambulatory, they cannot need, an anticoagulant. So you don't have to give them that, yeah? Okay, the antiplatelets. Okay, antiplatelets are a different class of medication. So what do antiplatelets?
It blocks the ADP receptors on the cell membranes.
They prevent what?
Clotting.
Very good. They prevent sticking of the platelets, okay? So it doesn't dissolve clots that may already be present in the patient's body, but it does prevent the clumping of new.
Professor, they don't work the same way as the anticoagulant?
That's what she's saying.
No, an anticoagulant prevents any clots from forming.
Okay.
Antiplatelets don't
Oh, prevent?
take care of things that are already present, but they prevent new ones. It's a different class of a medication.
But also anticoagulants prevent only, does not take care of any,
No,
Previous one.
anticoagulants
Blood
in
thinner.
a higher dose can dissolve.
oh, okay.
So what's in the give it to the patients who have a DVT and use them to normally bearing until blood test done? So the first one is anticoagulant.
Say that again?
When patients have a DVT,
Yes.
they use for them, but they put temporary for non-weight bearing because they're afraid that the blood clot can move
Correct.
around and
Yes,
Good.
correct, correct. So some names of some drugs that are antiplatelets, Plavix or Bril. Aspirin, what's the name for aspirin?
So what would be an ideal patient to receive a clopidogrel versus an aspirin?
Oh, that would be your cardiac patient, for sure. For sure, especially if your cardiac patient already had a clot removed from their artery, they're gonna definitely be put on an antiplatelet. They'll be on an antiplatelet for at least a year, for sure.
So someone who's had
It's a
had a
little more
heart attack?
potent, it's more potent. Acetylsalic acid or aspirin, for years, they have been giving that in, a baby aspirin.
Baby aspirin.
To cardiac patients to prevent any platelets from sticking together. That's what we call a prophylactic medication, so we're giving it just in case, right, so the patient doesn't develop it. We just know that if we say anticoagulants, you can draw from your enoxaparin, your heparin, or even your warfarin. Now, with these medications, what do we need to look for? Bleeding. Bleeding, definitely. So, do you think I would administer these medications to a patient that had a history of, say, a GI bleed?
No.
No, but I would have to, not I, but the provider, would have to weigh the risks versus the benefits. Okay, so if we could avoid it, we would. But if we needed to, because what if the patient has a history of GI bleeds and they have a history of a DVT? Oh, that's a
Problem.
quandary, right? So you'd have to make sure you protect as best as you could the GI system, but they might need maybe a lower dose.
Maybe the lowest dose they can give and also monitor the GI.
Yeah, and then you would have to, as a nurse, monitor them very carefully. So some symptoms of bleeding might be, blood in the stool,
Or urine.
right? Blood in the
Can it
urine.
be also like a bruise in the body?
Yeah, they could have little, what we call petechiae, little tiny bruises on the skin. We call them petechiae because they're usually small. That's it, just slim. I tried to be a little more. Sorry.
But I always wonder
that way.
because I'll see the people who take the anticoagulant and they always have, you know, you can just look at their skin and see that little red something. But they don't have it.
But maybe the dose needs to be adjusted.
Like I always see
So it's a sign of
I
bleeding?
actually thought it was normal.
Yeah.
They have
Or
what,
maybe
red?
even sometimes
Asthma?
if you brush your teeth and all of a sudden your gums start bleeding and they haven't bled before, that could be a sign, you know. So that's something that you as a nurse would watch out for or ask your patient about, you know, because your teeth aren't supposed to bleed.
Yes.
Okay, when you brush. And those little red pinpoint petechiae dots, they're not normal. You shouldn't have it. Okay, so if you do, then the patient needs to be looked at.
Okay, it means that now
اللي هو
right
جبت هدول الأقلام مش محصلة ولا واحد بالشيء.
Correct. So
ماما
if
بدنا
the
نجيب لي واحد.
patient is taking an anticoagulant, we really should teach them that they should not take aspirin for a headache. Because
add
what
more
does
to it.
aspirin do if you're taking an anticoagulant?
We're
what
gonna
it
enhance
is,
the,
it has an additive cumulative effect and it enhances the chance of the patient bleeding. Because you're putting two of them together, right? You're putting two of them together, which is why, just as an aside, if your patient is on an anticoagulant, they're going for surgery,
They have to stop.
they're gonna stop it.
Yeah.
They're gonna stop it.
Professor, what about ibuprofen? Ibuprofen? Is it the?
Ibuprofen, if they can normally take that, that's okay, that's an NSAID, so that
Which one
works
is-
differently.
Is it acetaminophen or one of them that also has this, it does not have this, like this thing that
The
makes the blood?
additive?
Yes, no?
It's usually aspirin.
Oh, okay.
Aspirin is more for bleeding, not so much Tylenol or the NSAIDs, not so much. Okay, and if the, person wants to shave, if it's a man and they're shaving their face, or if it's a woman shaving her legs, we would teach them that it's safer to use an electric razor, not a blade razor, because if you nick yourself, you can bleed a little bit more, right? Because you're on these medications. So that's super important. Okay. Let me see, what else can I show you? Oh, lab results. What would we monitor monitor if they are on an anticoagulant.
Liver function?
Pressure.
Well, you
INR.
would, but you would also monitor
Pressure.
your INR. Your INR. And the normal is 2. Yeah.
While on the medication or when not taking it?
While they are on the medication,
So therapeutic level is 2.
yes.
This is for antiplatelets?
Anticoagulant.
Anticoagulants. And if you suspect, you'll learn this later on, but if you suspect your patient is bleeding because they've had too much anticoagulant, the antidote for an anticoagulant for heparin is protamine sulfate. We don't normally test you on that, but that's been a board question for as long as I can remember. The antidote for heparin is protamine sulfate. Protamine sulfate. And if a patient is on a heparin drip, say they're getting heparin IV, you're gonna monitor their PTT. That's just a lab value, and that should be, the normal is usually, 40 to 87 seconds is the new normal.
But that's therapeutic, right?
That's therapeutic, correct. If I just took somebody's PTT and they weren't on heparin, the range would be 20 to 35. So therapeutic is like 2 to 2.5 times the normal, so it's between 40 and 87.
What is the normal?
20 to
20 to
35
35.
seconds. And remember, if you're giving enoxaparin or heparin via subcutaneous injection, where are the subcu sites?
Abdomen, oversized, 2 inches around
Right, always avoid the first 2 inches around the umbilicus, very good, very good. And we never aspirate when we're giving them, we never aspirate when we're giving an injection, or we never massage. We never massage. If we are giving a patient warfarin or Coumadin, we also monitor to make sure that the levels are therapeutic. An antidote, if they have a little bit too much in their system, is vitamin K.
Okay, yeah.
Antidote for warfarin is vitamin K, and it's protamine sulfate 4. And warfarin or Coumadin, I told you that's been around for a long time. That's used more for long-term prevention or management of folks that have a long-standing history of either a DVT or a pulmonary embolism, and they've had several episodes. Also, it's given for atrial fibrillation.
Safe for patients with any antibiotic, eat bananas.
Bananas?
Yes.
Yeah, you can eat banana. You shouldn't eat more than one a day though, because it has high potassium.
So there is no need to monitor.
No, you would just monitor their blood work. Yeah, but if they're eating 5 or 6 bananas a day, yeah, that's a bit much. Yes, yes.
Counteraction.
Definitely.
Counteraction.
Okay.
She said if you have too
I
much in your
told
body.
you clopidogrel or Plavix is given for, folks with
There's too
coronary
much. You wanna
conditions.
change that, put a
It
counteract.
reduces the incidence
You're
of
gonna
heart
give the
attack,
person
it can be given for folks
Vitamin
with
K.
stroke. And the
Professor,
normal, what?
sorry, you said something about vitamin K that I didn't understand. I just
What
heard
don't you
I
understand?
just heard vitamin K and I didn't get what you were
What's the
saying.
antidote?
Like,
you don't take it. You're not supposed to be taking, vitamin K with warfarin.
If there's too
Subject to
much
antidote.
warfarin in your system, the antidote is vitamin K.
It's too
Yes,
much.
it's too much, it's too much. But I was
Self-
giving you,
effect.
some information about Plavix, so we locked somebody out. Remember, with the antiplatelets, you need to monitor the lab value of the platelets, okay? You need to monitor that, so the normal platelet value is 150 to 400,000. You'll learn more about that when you do nursing 22 and you're giving patients chemotherapy, because that always drops the platelets. So they monitor that for you. Okay.
You said it drops,
And aspirin, acetylsalic acid, the dose can be a baby aspirin, which is 81 milligrams, or it can be the full dose, which is 325 milligrams. Very good, okay. What's special about aspirin?
It has
Aspirin actually can do 3 things.
anti-inflammatory effects,
So give me the
Fever.
words.
Fever.
No, that's not the word. The
Like-
word is
like
antipyretic,
anti-inflammatory,
anti-inflammatory, very good. And what's the third one? No?
analgesic,
So
anti-pain.
listen to me carefully.
Good one.
Aspirin, antipyretic, analgesic, and an anti-inflammatory. It's one of the only drugs out there that actually have those 3 big uses.
What do you mean by
Analgesic pain.
Okay? Remember that, that's important. And again, if you're taking too much aspirin, you have to watch out for bleeding.
Bleeding.
Bleeding. Okay. So you're gonna assess stools, you're gonna look for black or tarry stools, hematuria, blood in the urine, GI upset. Aspirin should be taken with food for that reason. And ibuprofen is an NSAID, that's a different category, right?
So only aspirin has to be taken with food, everything else we discussed before, it's fine?
Well, the anticoagulants here, the Lovenox and the heparin are usually given via sub-Q injection. Warfarin can be given PO. And the antiplatelets are PO and they can be also, some of them can be,
Injected?
Okay, PPIs. PPIs, proton, guys, pay attention. Proton pump inhibitors. What are these? The anti.
for the
It's, and why do we give them? For GERD. What's GERD?
Acid reflux.
Gastroesophageal reflux disease is the name that goes with that acronym. There are so many people with GERD, okay? Young people, old people, okay? Stress can give you GERD. Too much alcohol and laying down at night can give you GERD. Okay. So these are just some of the medications that we can give. Omeprazole, that's the generic, Prilosec is the trade. Nexium or Aprismolol, there's also Protonix or Pantoprazole. Okay, that's one that's not listed here.
There was another one, generic for omeprazole, ranitidine.
What's the name?
Ranitidine,
Yes.
Yeah, but they withdraw ranitidine from
That's right, and why did they?
because it causes cancer.
Yeah, isn't that
I
something,
kept taking
huh?
ranitidine for 20 years.
Oh my God. Isn't that something, right? They, after it's been on the market for that long a period of time.
Professor, the omeprazole should before meal or after?
Before meal, 30 minutes before meal.
It should be before.
Before half an hour.
It should be before. But more importantly, especially with the young folks, GERD can be very serious, okay? I know a lot of young people with GERD due to stress. They have to find a way to manage their stress, because if you have years and years of gastroesophageal and everything keeps repeating on you, you can actually change the cell structure in your upper GI tract. Okay, you can get something they call Barrett's esophagus. We're not going to test you on that, it's just trivia. And they can get cancer. Yeah, it's that serious. It actually changes the cellular structure in the upper GI series. So we always, counsel the patient, some stress reduction activities. Definitely no fried or fatty foods that are gonna just promote that regurg. They really gotta cut down on their drinking if they're doing a lot of drinking, cause that just promotes it. No acidy juices like orange juice, pineapple juice, because that just aggravates it. So you see, it's just not the med, it's lifestyle that you need to incorporate with that as well, okay? All right, electrolytes. Why are electrolytes important? Why are they important?
Dehydration.
Yeah, I mean, we can't have our electrolytes out of balance, especially, I said before, potassium, because potassium affects the electrical conductivity of the heart. So that's very important. We may need to give supplements like iron, thiazole, or ferrous. Why would we do that?
Someone who has anemia.
Anemia, very good. Low hemoglobin, very good.
I have anemia.
Also pregnant women also, right?
They try not to, because a side effect of
Constipation.
iron is constipation.
Yes.
Dark stools and constipation, and a pregnant woman does not need to be constipated. Yeah, that's not a good thing. And stool softeners, why would we give stool softeners?
Someone who's constipated, and I think it's I think my dad had it, for when they have heart problems, it's not good for them
Right.
to be constipated.
It's not good for anybody to strain.
Strain.
Okay, if you're, first of all, in an elderly person, they're very easily constipated because their whole GI tract has slowed down, okay? Add to the fact that they might be sedentary or wheelchair bound and not as active. Add to the fact that they're not drinking enough fluids. All of that adds to, we'll talk about that when we do fecal, but that all adds to constipation. And if they strain to have a bowel movement, they can put pressure on their vagus nerve, okay, and the vagus nerve will drop the heart rate. So it's not uncommon for an elderly person who's been sitting on the toilet trying to move their bowels to faint, because they're pushing, and that's what happens with the
Heart rate
vagus
drop.
nerve. Yeah. So stool softeners are in a little bit of a different class than an actual laxative. So there's all different kinds, but a stool softener just kind of allows the GI tract to absorb a little bit more water, making the stool softer, so it's easier to pass. Okay, so that's the idea behind that. You're going to see that if you haven't already in the nursing home. They're definitely on a lot of stool softeners. Okay, and then we have some other medications, anticholinesterase drugs, donizepam or Aricept. Do you know what we give that for?
For people with dementia.
People with dementia, very good, very good. Alzheimer's disease, they're doing a lot of research with that. Okay. So some common side effects for this particular drug is bradycardia, hypotension. In some patients, it may cause urinary retention and difficulty urinating. And it also, in some patients, can cause bronchospasm, so they can't breathe.
So you stop the medication?
Did you say
For sure.
Hypo,
Hypo, low, low.
You said bradycardia,
Bradycardia,
hypotension.
hypotension, urinary retention,
bronchoconstriction.
bronchoconstriction, yeah. Okay. And anti-epileptic drugs, most famous one is Keppra or levetiracetam. Okay, this is an important drug to know. We use it commonly for the treatment of seizures. People with epilepsy, it's a long-term medication. So folks that have a seizure disorder, they take these medications for life. This is not something that they stop and start. They take it forever. And if they skip doses or miss some doses, their serum blood level drops, and that raises the risk of them having a seizure. Okay, so I have seen very well educated people that I work with that have this disease, and they run out of their meds, they're too busy, the pharmacy, I don't know, they forget, and they could be off their medication for less than a week, and they're gonna have a seizure. They're gonna have a seizure. So we teach these folks that, you'll learn more about this in 22, that this is a lifelong thing, you know, and with some people, until they get the dosage right, it can be, you know, debilitating, and it can affect their quality of life. So, you know, we always try to have them, to the best of their ability, incorporate this routine into their life, so it's kind of like a normal thing for them. But so know about Keppra. Okay, it's safe to give in the older folks or people with liver disease, but it's not good for folks that have kidney disease, okay? And it can interact with other medications, so you always want to check with the provider before this is prescribed.
You said safe for people with liver disease, but not safe for who?
Kidney disease. Okay, because it interferes with kidney function. Common side effects of this medication: dizziness, drowsiness, headache, fatigue. What's the medical term for dizziness? Do you know?
Syncope.
Syncope that's good. What's another one? Syncope is dizziness with fainting. Vertigo.
That's the ear for the.
Well, it can be because of the ear, but it's dizziness.
Does it cause it?
It can be a side effect.
Yeah,
It
'cause
can
it's
cause
your
dizziness
balance.
or vertigo.
So do you
Yes.
stop it in this time?
You never stop anything before contacting the provider.
Or you hold it, you don't give
Remember
it.
I said Keppra is for seizures.
I don't
This
mean
is
like
a
as a nurse to
lifelong
stop the
thing.
medication. Yeah.
Yeah, no, this is lifelong.
But Professor, if the patient is having those side effects,
They
and I'm
may
supposed,
titrate. Again, it's always risk versus benefit.
right, but my question is, if we have a question in the exam saying, what would you do first? What would be your priority? I'm not gonna give the medication, I'm gonna hold it, right? Then contact the provider right away.
Yeah, of course.
I will
you
not
always-
give it because,
Yeah, you will
right,
always contact the provider. The provider would make the decision.
okay.
Yes, for sure. Okay. So let's talk a little bit about the analgesics that are the non-opioids. Okay, ibuprofen, or Motrin. This is over the counter. It's the classification is an NSAID and Tylenol or acetaminophen. You gotta be careful with these medications because Tylenol has a black box warning. Okay, so you can't give more than X amount of grams in a 24-hour period because Tylenol or acetaminophen is metabolized by the liver. That's the organ. And if you give too much Tylenol, you can actually put a patient in liver failure. So the caveat with these over-the-counter medications is the general public thinks, oh yeah, it's over the counter.
Right,
So I
yeah.
can take as many as I want. You know, I took 3 Tylenols, extra strength, because I had a migraine. And gee, maybe later on in the day, you know, it got a little better, but I need some more, and they take a few more, and they've actually overdosed themselves, you know? So we need to educate the general public that even though it's over the counter, you gotta keep track of what you're taking. You can't just take it like candy. So remember, Tylenol is an antipyretic, so it's good for fever. It's an analgesic, so it's good for pain, but it's not an anticoagulant. Right? Only aspirin has all 3 qualities.
You said an antipyretic.
You mean not anticoagulant,
Antipyretic, you can take it
anti-inflammatory.
if you have a temperature, and you can take it as an analgesic if you have pain, right? A lot of people with regular osteoarthritis, they're stiff in the morning, they take some Tylenol.
Professor, you said it's not an anticoagulant.
It is not. Only aspirin is an anticoagulant. Aspirin has all 3 qualities. Tylenol only has 2 of the
Not
3.
anti-inflammatory.
No. It's an analgesic. Analgesic.
Pain.
And that's for
Pain and fever.
And fever, right. Right. It has no anti-inflammatory properties, none, okay? And remember I told you it has a black box warning. So if somebody has liver disease, is Tylenol a good choice?
No.
Definitely not, definitely not. Okay. However, Tylenol is very often combined with an opioid, like oxycodone, right? So
Yeah.
it gives you the trade name of Percocet. Okay, that's Percocet. And they work together, the Tylenol and the oxycodone work together to provide pain relief. Okay, that's if you are, have a prescription for an opioid. Okay, but remember, like anything else, you have to assess your patient first. Remember I said earlier that if your patient has a lower respiratory rate, okay, the oxycodone is only gonna make
Depress
it
it
go
more.
lower. So you want to hold that medication, not give it, okay? And if somebody has an order for Percocet, there should be a very valid reason because opioids do have addictive properties. So somebody, like I said, with sickle cell disease, for example, they will develop a tolerance over time with each successive crisis that they go through, and they will become addicted to the opioids. So when they come into the facility, we try alternative ways and teach them to manage their pain so that they don't have to go straight to that opioid.
Then, Professor, can the person taking 2 opioids together, one stronger, for example, morphine and Percocet? Because
No.
the patient is not tolerating pain and refusing to do anything.
We don't like to combine narcotics because the risk of depressing the respiratory center is too great. You know, your patient will stop breathing. They literally will stop breathing. So that's not good. We also teach patients that if they are on an opioid, even if it's for a bona fide, medical reason, not to drink any alcohol, okay? Because why? Alcohol reacts with the opioid and it potentiates it, so it makes the effect greater, Okay, so I always say to the patient, pick your poison. Don't do both. Don't do both. You can't do both because the effect is that you're gonna stop breathing.
Oh, wow.
So decide what it is. Okay. We'll teach you when we go over the pain lecture to do the pain assessment, the Wong-Baker pain scale, and do your PQRST. So anytime you are giving anything for the purpose of pain, even if it's Tylenol, you're supposed to do a pain assessment. And then you come back and you reassess. Okay, was that therapeutic? Did the medication work for your patient? Okay? Always try and keep your patient pain-free. I'm a firm believer in that, whether it's with a medication or with an alternative. Patients should not be in pain. All right, was there anything here? NSAIDs, we talked about ibuprofen, Motril, Advil. They can irritate the stomach. Just be mindful of that, especially with folks that are stomach sensitivity, digestive sensitivity. Where does enteric-coated aspirin digest?
Stomach.
In the small
Not in the
intestine.
stomach.
Small
Not in the
intestine.
stomach. It bypasses the stomach.
Small intestine.
The small intestine, right? That's why it's enteric-coated, to bypass. Anything that's enteric-coated,
Do not crush.
don't crush it, and it bypasses the stomach and it gets digested in the small intestine, okay?
Does
Good.
it still affect the liver? If you
What?
take- and no, I have a question. That's my question. Does it still affect the liver?
Does what
even-
affect the liver?
The medication, like it, because most of the medication taken by mouth, it does affect the liver.
It's, remember we said yesterday, it's either the liver or the kidneys that metabolize. Those are the two
Right.
primary. And then secondary might be lungs, skin, you
Okay.
know, digestion, but it's usually kidney or liver.
Okay.
Yeah, for sure. All right, let's see.
Hypoglycemic.
Hypoglycemic medications. So medications for diabetes, that treat diabetes. We want to keep glucose within normal limits. What's the normal glucose level? 70 to 110. Very good. So a very common one is metformin or glucophage. It's an oral hypoglycemic medication. It can be used alone. Sometimes they use it in combination with other oral hypoglycemics. If it's given with insulin, it's going to potentiate or raise the effect that the body is already producing, so you gotta be careful about that, okay? Glucophage is absorbed in the small intestines, and the therapeutic result is that you would have a lower glucose level. So many adult onset type 2 diabetic patients are started on metformin, okay, to keep their glucose down, because we really don't want to put patients on insulin if we don't have to, okay? But a lot of times, the patient that comes in with a high glucose that the provider may give metformin to is because the patient is overweight and sedentary, because they never had diabetes before. Now they're older, so you know your body changes as you get older. So you tend to become a little slower. You tend, because you gotta push yourself. It doesn't get easier as you get older, it gets harder. And you gotta work harder to stay active. And also, it will raise the glucose. So if you counsel the patient on maybe decreasing some carbs in their diet, picking up their physical activity, maybe they don't even need to be on metformin. Or if they're on it, maybe just
Wean them off.
wean them off. But the patient has to do the work, okay? And a lot of patients, it's easier for them just to take a pill, and that's not good. You want your body to do the work so that you don't need the pill. You're gonna see as nurses, there are patients that have so much medication. Polypharmacy, I call it. And if you kind of do like a med rec and you look at the list of what they're on, you're like, okay, if I work with the patient, maybe I can get rid of this, maybe I can take them off this. So it becomes easier for the patient, but you know that medication is big business.
Yep.
Okay, they make a lot of money in this country. Can I help you? Ah, okay. All right, let's see, anything else? Sometimes they'll lose some weight if they're on this medication, sometimes, but that's not a reason to put them on the medication.
Professor,
Mm-hmm.
many doctors prescribe metformin to lower the testosterone.
To lower what?
Testosterone.
Testosterone?
So is it, I read somewhere like it causes diabetes for patients who don't have it?
Not that I know of, because it lowers your glucose, so why would it cause diabetes?
Like for long?
Not that I know of, but you mean, is that an off-label use for metformin? Cause I never heard of that. I just know it for, glucose control. No.
Is that the one that everybody's taking to lose weight even when they're not?
No, that's
That's
Ozempic.
That's Ozempic, but you see, this is what I mean. You can't take a pill to lose weight, you gotta do the work.
Yeah,
But
also
there's-
this one, they say it
But
causes
they
diabetes.
people are gaining back the weight and they're getting diabetes now.
Yeah,
They're
because
on limit
that's
because they
not
never had it
the
before.
function.
Yeah, this is the.
You can't take stuff that you shouldn't be taking if there's no physiological reason, because, yeah, the repercussions can be serious. Remember, it's a drug. There's no such thing as any medication that does not have a side effect. The thing is the side effect livable, or is it, bad for you? So, yeah, you don't want nothing. The less you have, the better off you are, trust me on that. Okay, and then we have insulin, which is the last one here on this slide. So insulin, obviously, you saw that in the video, how to mix the insulin. Okay, you need to know how to mix it in case you ever do need to mix it, okay, or if they ever ask you a question on the boards. So you're gonna always inject air first into the cloudy, and then into the regular, which is the clear. And then you're gonna pull back.
From the regular.
Yes, yes. And never shake your insulin bottles because you can create bubbles, just roll it in your hand. All right, that is it with that.
Professor.
Okay.
Professor. The medications that we need to know are just
All of them that are on the list.
because you said they're 20 something, but they're like actually 40 something. There are so many.
I
Some
know.
of them they're like those antibiotics and stuff. Also,
Everything that's on the list. Everything.
I have a question about someone on metformin. For them to develop lactic acidosis, does that usually happen within a short time frame or a longer time frame?
It depends on the patient, I can't, what's short term, define short term.
Like maybe within a day or two, or is that
Usually
something that happens
it's-
over time?
Usually it's not that fast.
Okay.
It's not that fast. Yeah, it takes a little bit of time. All right, let's quickly go through sensory. Okay, sensory is not